Hello, everyone. I'm Dick Deming. I'm Medical Director of MercyOne Cancer Center and founder of Above and Beyond Cancer. Welcome to our Cancer Education Series. It is supported by a grant from the Iowa Cancer Consortium. And you're in for a treat tonight. We have a guest. Our guest is Veronika Panagiotou. Dr. Panagiotou has her Ph.D. from Point Park University in Pittsburgh. She grew up in the Pittsburgh area, and she has her master's from the University of Pittsburgh and her PhD in community engagement. And she works for the National Coalition for Cancer Survivorship, which we also refer to as NCCS. And it's a wonderful organization that does great advocacy work around survivorship, especially advocacy and lobbying at the federal level. Veronika is also a young adult cancer survivor and has a track record in advocacy. She hopes that her work at the NCCS will give cancer survivors and their caregivers an opportunity to use their voice to impact public policy. So welcome, Veronika.
Thank you for having me. It's a pleasure to be here.
Well, it's great to have you not only with your professional expertise, but you've obviously walked the walk and you have a life experience that I can only imagine how meaningful that is for you to work for an organization that's helping others that have been on the journey that you have been on and are on as a cancer survivor.
Correct. Yes, I have the privilege of working with many cancer advocates within the organization. Our cancer advocacy and policy team is a coalition of over 700 advocates across the country who work with us to advocate for public policy. And so that's one of the programs that I take care of at NCCS. If you're interested in joining me at NCCS, feel free to go onto our website, which is canceradvocacy.org. And you can find that team, and there's a quick questionnaire, and you'll be connected to us to find resources as well.
Wonderful. And you're talking about advocacy, as a cancer doctor, I have the ability, one patient at a time, to help reduce the burden of cancer. But as an advocate, going up to Capitol Hill, whether it's to the State House or to the federal Capitol Hill, and helping to change public policy, you have the ability to affect millions. So the power of advocacy is huge.
Correct. And sharing our experiences with lawmakers, people that represent us, is very important so they can understand the decisions that they make and how they impact us in our local communities. So it's important at the local level, at the state level, and what we do at NCCS, we primarily work on Capitol Hill to make sure that cancer patients and survivors and those with metastatic disease are well taken care of within the system.
Yes. I am a volunteer with American Cancer Society Cancer Action Network, and we're actually having our lobby day here at the State House this Friday. And as you know, we come out to Washington once a year as well. Do you have cancer survivors and caregivers join in for your advocacy days at state houses or at the federal Capitol?
So we do every year our CPAT symposium, which is usually at the end of June, where we welcome survivors and their caregivers to Washington. And we do visits to Capitol Hill. Currently, with the pandemic and other things, going to Capitol Hill isn't as accessible as it used to be. So we do it virtually now, as you mentioned. So this year, hopefully in June, we will send details soon about we are going to bring advocates to Washington, even though we don't have much access to Capitol Hill, and do some professional training and some teaching around public policy in DC. And so you can come this year, and hopefully next year we'll be back at the Capitol again. But baby steps.
Excellent. Excellent. Well, we'll make sure that we promulgate the information about your organization. So if individuals encourage them to become part of the network. So
Absolutely.
tonight we're going to talk about the state of survivorship, and maybe I'll just turn it over to you, Veronika, to sort of set the stage. Why do we talk about survivorship, and why is it, if you've been treated for cancer and you're got that done and it's in the past, why do we make an issue of issues related to survivorship?
Sure. So to give you a little background about NCCS to kind of set the stage too, our organization was founded 35 years ago by cancer survivors for cancer survivors. And at the time, the lexicon around cancer was more associated with being a victim. And so our founders decided that they were survivors, that they survived their treatment, they survived the day. And so they then wanted to create better quality of life and quality care. As survivors watching, you know that when treatment ends, the ramifications of treatment do not end. Our bodies have changed. We have been introduced to the treatment that luckily has saved our life or prolonged our life, but there are long-term side effects. And there are issues that don't, not within the realm of oncology, our mental health, our sexual health. So there are other things that are side effects of the treatment, and we need to take care of those things too. And so every year for the past 3 years, we decided to, as an organization, that we wanted to pick priorities based on the experiences of cancer survivors across the country. And so we didn't want to make any inferences or the few cancer survivors who work at NCCS didn't want to set the stage for and representative of cancer throughout the country. So we do the State of Survivorship survey.
Gotcha.
And that is our research-based initiative to make sure that we represent everyone and find the gaps. And I'm going to go through some of this data. Know that this is just a small snapshot of the data we have collected. You can also find the full report. It's about 37 pages long. And it breaks everything down even into bigger pieces. So if I don't present something today, or if you have questions, if we collected such data, feel free to reach out and I'd be happy to see if we did. But this is a resource to everyone to be able to use it for things like grant funding and to find the niche in your cancer center. Is this a problem for us here, and give some ideas of what questions you should be asking. So you can go to the next slide. We'll start.
Veronika,
Mhm.
how do you, what database do you use? How do you find the cancer survivors that you reach out to and invite to participate in the survey?
Sure. So we are partners with Edge Research, and they are a firm that goes out. We set demographic standards of who we want to reach, and that research organization does a very good job of reaching across the country to their affiliates to find cancer survivors. And then also, I mentioned that cancer advocacy team. We have about 700 cancer survivors connected to us that we also poll every year. And we also, in our research, you won't see it in the slides that I'm going to show you, but we actually keep those cohorts separate. And you can see the difference between the national sample and those advocates connected to NCCS. Advocates connected to NCCS tend to have more health literacy. They've been advocates for a long time, and so they have higher expectations and can sometimes skew the data a little bit. So we keep it separate to make sure that we find the average cancer patient to see what their views are so that we can make educated decisions about what we should advocate for as an organization.
Thanks. And we'll go back to your first slide here.
Perfect. My first slide. So the first thing as an organization, our organization is looking for disparities in quality care. And so the average patient, 75% of them feel that their quality of care is excellent. And so to us, that seemed a little high based on what we know as an organization. And so during our focus groups, which we also do with some of the participants who answer our survey, we do focus groups as well. And some of the responses that are received, well, I'm alive, so it was excellent care. Well, we know as an organization that the level of symptoms that you have being managed, is your care managed by multiple practitioners? Is there no stress involved in that? Connected care is very important. Being a team is important. And so that number, 75%, a lot of those survivors are grateful to be alive. And I too am grateful to be alive. And so, but we know we can do a better job. So if you look at, for instance, you can see the disparity. Only 57% of our young adults said their care was quality. And so that demographic is okay with questioning the quality of care. So you can see the stark difference. You can also see the disparities among the ethnic groups, white, Black, and Hispanic. If they're in the same environments, their quality of care and their treatment plan should be the same, and they are not. So that is a problem. The other thing, so I want to explain the support excellent, support just fair. So cancer survivors who said in a different question of the survey that they had an excellent support system rated their quality of care as well above the national average at 90%. Those who said that their support was just fair ranked the quality of their treatment as 51%. So that tells us that and there's a slide to better define what support is and who is giving support. But this tells us that comprehensive care that includes everyone, including family and faith and nonprofit organizations, overall, they can support the patient better and they have a better experience. You can see too that those still in treatment in the first year out have a lower perception of their care versus people who have continued to live on. And so as people are going on and moving on and living their lives, their perception of their care becomes higher.
Yeah, that statistic with the support, 90% favorable if you had good support, and 51% favorable if just you have fair support, certainly is meaningful. And I say all the time, taking care of someone who has cancer is more than just killing cancer cells. It's taking care of a human being and their family and the support that you need to get through it. If all you focus on is the chemo and the radiation and the surgery, you're not going to get the results you want in terms of the holistic care of an individual.
Absolutely. That's and two, this reveals, what are the gaps that we need to recognize and we need to fill based on the needs of a particular race of people and how their culture works. For instance, the Hispanic and Latino population, their caregiving unit or their support unit is their entire family, plus potentially their extended family. And there is a co-decision making process. And so there needs to be space for that within the healthcare system so that patient receives the best care possible. So those are the things that we need to take into account, and the system needs to be able to adapt to the culture and the needs of every particular patient that comes in the door. The young adult survivor who comes in, for instance, one of my colleagues, I teach as well. And one of my colleagues shared with me that one of her students who's from out of state potentially has a tumor and there's no one to go with her. So my colleague is going to go to that oncology appointment with her. And so we need to be flexible about creating support systems, non-traditional support systems, and recognizing if someone walks in the door alone, what can we do to find a support system that'll work for them to get them through. Okay, so let's go on to the next slide, if that's okay. So a part of quality of care is how many symptoms that you experience through your treatment. And so that's how we gauge if there is good communication, if there's trust between the physician and the patient, and if there are referrals, because we know that oncology does not have the answer for everything. And so the next best thing is knowing who to refer your patient to. And the trust of the patient to say, these are the issues that I'm having. And so if you look at the national sample, a wide range from as low as 16% to fatigue being 45%, patients experience those symptoms. But as you get into the demographics, the 18 to 39, they're experiencing more symptoms at higher levels, as well as you can also see the issues that people have that can be easily fixed with a prescription are typically lower, but not in all cases. And things that can be fixed with, like I said, a prescription or a cream or a test to be identified as having a symptom. There's no test to find the level of fatigue that you're experiencing. There are some things, but that's something that's a little invisible and so harder to take care of. And you can see that across the demographics, the numbers that are in the teal color are significant research that we can make a generalized statement across the country that this is predominantly what these demographics are experiencing.
And when we look at that list of symptoms, obviously some symptoms can be related to the cancer, but a lot of the symptoms can be related to the cancer treatment.
Mm-hmm.
And so, and especially as we get into survivorship, where they're not undergoing active treatment, these are many lingering side effects.
Mm-hmm.
You mentioned, yes, everyone knows, well, okay, we need to do the surveillance for the cancer that was treated, but it's really more than just the physical. It's the psychological, the emotional, the philosophical, the financial,
Mm-hmm.
the sexual, the spiritual, all of those the cancer and cancer treatment can have lingering effects on all of those dimensions.
Yes. And two, I find that when treatment ended, the long-term effects that, for instance, I did not have at that moment at the end of treatment. That sometimes they pop up 2 years later, 3 years later. As I sit here 8 years later, I have more comorbidities that are somewhat related to my initial diagnosis and treatment. But the reality is not only we can't expect to have perfect health. we need our health to be managed. We need to be well taken care of. And things are going to pop up that aren't even cancer related, but might be more severe because we did have that treatment. The other thing I find is because I have that cancer diagnosis, I'm a more complicated case. I hear that often. Oh, I don't think I have the expertise. I can deal with a thyroid issue, but a thyroid issue with cancer treatment 8 years ago, I don't know what that means. And I don't know if the standard treatment will work for you because of my cancer diagnosis and how my new the chemistry that I have. And so there's a lot of experimentation that goes on, I find. To be able to do that, and it takes a lot of trust and communication to live my best life, and that's definitely the goal.
As you know, it's an excellent point. There comes a time, depending on what cancer you had, where the chances of that cancer coming back very, very, very small. But the implications of the treatment that you had on your ongoing life, you mentioned that some of the side effects happen a lot later. I mean, chemotherapy induced cardiomyopathy, the effect that chemo may have on the function of your heart muscle, may not become manifest in terms of symptoms until years later. Some of the delayed effects of radiation, the scarring that happens years later. And one of the reasons we've just developed a survivorship clinic is that many primary care physicians who are very, very knowledgeable at treating many different things may not know of the delayed side effects that can happen because of the cancer treatment and the impact that can have on managing other diseases.
Absolutely. And even to find a primary care physician in your community might be difficult too. Depending if you are in a rural setting. Unfortunately, access to healthcare across the country is not equal. And so trying to do the best that you can with the resources that you have in your community. There are some, and we'll talk about potentially things like telehealth that might be able to give us more access to more options for us. But yet, we're dealing with, talk about a policy issue. I have a cancer advocate who lives an hour outside of the Massachusetts border. She lives in New Hampshire, but an hour or two away from Dana-Farber, where she gets her care. And so now she cannot do telehealth from New Hampshire, even though that is where she goes. And so, these are complex issues that at NCCS, we are trying to figure out some innovative solutions so that we all can get the care, the quality care that we need. So let's go back to those slides. Okay, so another aspect, and I loved that you touched on the fact that your cancer center has a specific place for those with advanced and metastatic disease. We find that our advocates don't feel comfortable or don't feel welcome in a typical survivorship clinic because they feel that they haven't survived cancer. Many advocates, they use a metavivor as a word to describe themselves, or a thriver. And of course, at NCCS, we welcome descriptors that people feel comfortable with to describe the situation that they're in. But we also want to advocate and make sure that they receive quality care. And, just because they have a terminal diagnosis does not mean that they don't have the right to live the best life with the time that they have.
Yeah.
So,
and Veronika, and I feel that one of the things that we provide in the Living with Cancer is this philosophical perspective that is so important. It's part of the question I have for every patient that is living with cancer is, what has brought you the most joy since we last visited? And this philosophical approach of even living your life with an incurable disease, part of our human obligation is to find joy and spread joy, and spending some time thinking philosophically on what provides joy is an important topic in our Living with Cancer clinic.
Absolutely. I mean, that to me is those who are managing those diseases, they deserve they deserve that joy. And so you can see from the slide, though, that many of them are not, their quality of life is not great because their symptoms are not managed. When we compare them to the national sample of what others are experiencing and how their symptoms are managed, you can see that the light blue is drastically different for those patients. And so, what can we do? The research that is needed to be able to give them a quality of life, as oncology does a great job of expanding their life, right?
Mm-hmm.
We're doing clinical trials, new treatments, and we're extending life, but at what cost? And so,
Veronika, do you have any data that looks at their perception of how good their care was, whether they were the national sample or those that you sampled that are metastatic? Is there a difference in the perception of the care that they're receiving?
of the quality care, I believe that it is definitely something that is in the report of the overall quality. The national sample was 75%. I don't know what it is off the top of my head, but it is definitely in the report of what their we list out all the demographics.
Okay.
So that is definitely something that we can look up. Absolutely. Okay, so we can probably go to the next slide. Okay, so here it is, the costs of care. And as you can see, the national sample, so we look at something called financial sacrifices. And so for us, what's a financial sacrifice? A financial sacrifice is putting off a long-term purchase, whether that be a house or a car, putting off having children or a wedding, not being able to pay on past debts, whether that be a mortgage or student loan debt, not being able to live a life that includes normal things that have big price tags, like going on vacation, for instance. So that's the definition of what we call financial sacrifices, which we think are just as important as things like not being able to pay. You may still be able to afford to put food on the table, but these are quality of life issues that cancer survivors should be able to live a full life just like their peers. And so you can see that the 64% of young adults have made at least one, but the data is significant of multiple financial sacrifices. And the Hispanic, Latino, and those with metastatic cancers as well are very disproportionate to the national sample.
And so obviously we see the young adult, which you define in yours as 18 to 39, is most significantly impacted in this regard.
Absolutely. Yeah. Go to the next slide. So the other measure, there's a lot of research around financial toxicity. And that to us is the financial cost. But there are other costs of cancer that should be just as recognized and should be taken into account. So for us, that includes the physical cost. For instance, having the energy to make it through the day, and the physical changes to our body as well. So that's the physical cost. The emotional cost is more of the uncertainty of the future, processing the trauma of the pain in the process of going through cancer treatment, should be recognized. And then as well, the financial cost, having the financial support that you need to take care of your family, to live your best life, and to make sure that you can have access to healthcare. There is some research out of the American Cancer Society, for instance, that says the data that was just at the ASCO GI conference out of San Francisco a couple weeks ago was that a better predictor of survival of colorectal cancer is if you have insurance as opposed to the stage in which you are diagnosed. Whereas before, the saying is, oh, well, we want to find it early so that, we can cure it. You'll survive if we find a stage 1 or a stage 2. But actually a better indicator is if you have insurance, even if you're diagnosed at a later stage, having that access to care can be the difference between living and dying. And so, for instance, insurance and the affordable care is definitely at NCCS something that we advocate for at the federal level, because it is such an indicator of being able to access care and surviving.
We can come up with another $250,000 a year treatment, but if someone doesn't have access to it, it's not going to advance cancer care and decrease the burden of cancer. So access is so essential. Both physically having access, because there's providers in the geographic area you live, but having the ability to have insurance. If you don't have insurance, you're not going out to get the surveillance, the screening, and you're not going to have access to the best possible care.
Yes. So being able to getting access. I mean, we can make insurance has to be affordable to be accessible as well. So that's also an important distinction. You can have a marketplace full of insurance plans, but if you can't afford them, you might as well not have access to them. And so that even that component has to be the toxicity of just maintaining insurance coverage. You can have, but then you can afford the premium. You can just afford the premium. But then what about the deductible?
Yeah, the copays and deductibles now.
Yes.
We happen to, here in Iowa, we did do expansion of Medicaid, which was a huge benefit to many, many people. And we're still at the federal level and in other states advocating for states to expand Medicaid to help those in the lower incomes to be able to have affordable insurance options.
Yes. It is important for those in that socioeconomic status, but it's important for everyone to have an affordable option based on where you are in your life. There's no reason that everyone shouldn't get the care and the surveillance that they need, and for their families and their children. So that's very important for everyone. It's everyone should have access to affordable healthcare, no matter what place you are in your life. So that's important to us. So that's something that we work on. For instance, I'll share. I was 25 and in college getting my master's. Before the Affordable Care Act 8 years ago, there was a moment where most insurance was connected to employers. And when my mother transitioned to a new job, they said, oh, well, we reimburse on the private market and you have to qualify. So there was a period of 3 months where I did not have health insurance. And I thought, okay, the marketplace opens up in 3 months. I'll be fine. I'll get through those 3 months. I didn't make it through those 3 months. I was then diagnosed with non-Hodgkin's lymphoma, very sick with no insurance in the emergency department. And the first thing that my mother said to the physician was, "Will you take care of her?" Not what's my treatment options, how are we going to get this fever down? It was, will you actually take care of her? And so I've been in that spot myself, and it is heartbreaking, because not only you might be able to get the treatment in the hospital, but then you need those prescription drugs to be able to get through. I went through the first month of treatment without insurance, and every side effect, whether it was fungus in the mouth or the blood clot, I needed to be able to access a pharmacy, and the only way to do that was with a credit card. So it is we are in a better place than we were 8 years ago, but there's definitely still room for improvement in the system that we have. Okay. So we can go to the next slide if you'd like. Okay, so here's the slide about support systems being key to being able to get through treatment. So we looked at the national sample, just is about only 50% have immediate family as a strong support system. So that leaves quite a bit of people who don't have someone to support them. We see that it's lower, even lower amongst our 18 to 39-year-olds, our African Americans, our Hispanic survivors, and our low income survivors. The immediate family is not as strong, but the national sample isn't great either. And if we go back to those who had excellent care, 90% had a strong support system. So it is very important that we're able to recognize who the support systems are for our patients. You can see that they identified their doctor or their healthcare team, those who identified them as their support system, is pretty low. It's shockingly low, 13% for the national sample. Actually, young adults feel a little bit better about their healthcare team. African Americans, even less. And the Hispanic and the low income, Hispanic is a little bit better, as well as low income is near what the national sample is. But that's definitely room for improvement to build some trust, and to build more comprehensive teams to be taking care to get through treatment. And then another important aspect for us, based on the demographics, the most significant other support systems that were identified was faith. So faith-based organizations, and the Black community finds that their faith is very important to their support systems compared to the national sample. But we can see that we need to be creative and recognize other support systems so that we can get survivors to the 90% satisfaction with their treatment.
And I would imagine that there might have been some other options that aren't shown there. So I think of my patients, and oftentimes their work community of peers can be tremendous support, and obviously friends can be tremendously important as well. But you're right, nobody gets through this alone, and having more support. And especially, as a professional healthcare provider, we have really worked hard to bring on more for example, nurse navigators and financial counselors and dietitians, and more a whole team approach as opposed to just, treating the cancer cells.
Mm-hmm.
And uh, I've just seen the difference that our patient population relies on us having those services in place than when they thought, in decades ago where you just kind of came for your treatment.
Yes. Yes. Yes, the supports and other, local nonprofits are great, filling the gaps, in the young adult community and other communities. They're filling the gaps. The pediatric, I like to say the pediatric oncology space. I mean, talk about those organizations rallying and supporting. I think they do. Their system is maybe even better than the adult system, and there's a lot to learn from each other in creating positive spaces that encourage or have the opportunity. There can be opportunities for joy, even in the darkest of times, in the most painful of times. There are little moments that we just have to be able to create space for our peers, our coworkers. And it's been hard in the pandemic, not being able to have the people around you that you need to keep everyone safe. And so, how can we be innovative? For example, using telehealth and other things, recorders, and just so that the information can be passed along, been absorbed, and then the best decisions can be made with your healthcare team. And how can we do that better?
And I'm glad you did mention not-for-profits, because certainly here in central Iowa, American Cancer Society, Above and Beyond Cancer, the Army of Pink, Leukemia and Lymphoma, there's a number of organization not-for-profits that provide tremendous education, support, and services and programs that help individuals and their families get through.
Yes, we're definitely a community, and there's always room for improvement in any space, but we are living longer, which is, that brings me talk about joy, that we're living longer, that we're going to live better lives, healthy lives, and we can only do that together.
Well said.
Perfect. So you can go to the next slide, I think. Okay, so this is a slide. NCCS is interested in the perceptions of telehealth. If patients like it, should we use it in the future? And we have mixed results here. It's not as straightforward as you would think. Some patients like it in specific situations, sharing test results, consults, regular well visits, follow-up appointments are pretty at the top of the list. But at the same time, some prefer inpatient or in-person appointments, that first visit with the healthcare provider. Physical therapy, even though some have been trying to do as much with telehealth as possible, there is nothing like in-person visits for that. But still, you can see surgical consults are 80% on in-person. Well visits are 75%, even though on the other side, that question, what were excellent or good visits, 77% said a regular well visit via telehealth was great. So this tells us that it should, the conversation with the preference, that everybody is going to be different. And everybody has a priority as far as what they would prefer. So how can we, in a very healthcare system, how can we adapt to that preference, can be a little tricky. And that's something that we're going to have to work on. We don't want to pigeonhole people into an appointment type that they don't like. But at the same time, we don't want to take that option away from a patient that prefers that option. And so that's the greatest piece of advice for the telehealth. Things that can be enhanced by telehealth, clinical trials and access. But at the same time, our survivors in rural communities with very little broadband and don't have the gadgets to be able to afford to video chat with their provider, plus our older generation who doesn't have experience with these devices like the younger generation. There are so many the equity in telehealth is wide. And so we have to do the best we can with the situations that we're in. But at the same time, it seems to be a potential option that we just need to figure out a little bit better.
Yeah, we've all been, so before the pandemic, we really didn't even have a system in place to do telehealth. I mean, we talked to patients on the telephone, and in some way, shape, or form, that's telehealth. But it was, we've always been giving results. I mean, I see a patient, and we've had a long visit, but then they have a lab test that takes a couple days to get back. Sharing that information has always been the standard. We haven't charged for it. You couldn't do a phone visit, and but the telehealth we obviously started doing during the pandemic. The one thing that rings so true is that first visit. I mean, establishing it's a relationship. In cancer, you very rarely see a cancer doc once and done. It's the beginning of a relationship.
Yes.
And to be able to get that relationship on really good, firm ground by seeing and being present with someone in a room, it makes then the subsequent visits via telehealth so much better when you already know this person and they know you and they know the family. So that part rings true. I would say there are some patients that even that prefer in person because of the warmth and touch and relationship that happens when two people are in the room together. And there are others that would probably go back and forth and say, you know what, if I can do this from my office and not have to take off work and drive a distance and park, I already know you. Let's just do it that way. And the way that we have improved the visual aspect, so it's not just a phone call, but you can engage eye to eye and see facial expressions and create more empathy and compassion with better video capability when patients have it. But as you pointed out, not everyone has access to that. Not everyone knows how to use it. And there are some patients who would prefer to drive an hour and a half than be told they have to figure out how to use a computer.
Yes. And yes. And for me, who's a blood cancer survivor, they need some blood, and I can't do that through a computer screen.
We haven't quite figured that out yet.
that hasn't happened yet.
Someday, I'm sure we will.
Someday, we might be able to coordinate me going to a lab before within 24 hours of having that visit with the results in their hands. Maybe one day we'll get to that sophistication
and Veronika, I actually do that. I treat a lot of patients with prostate cancer, and the PSA is a blood test, and so we will send an order to their local hometown lab hospital, and they'll get the blood test done a couple days, and then we'll meet via telehealth for those patients that we've already got a relationship. So that happens. But I imagine someday, our iPhone will have a little needle that pops out and it'll prick our finger, and and we'll actually be able to get the
Well,
results.
I saw an interesting piece of text, speaking of the GI conference in San Francisco. An oncologist who works in AI talked about the stethoscope that's going to be able to, you're going to be able to use it via telehealth, so the patient will use it and record their heart, the sounds that their heart makes, and it'll transfer it to the physician on the other side of the camera, and he'll be able to listen to what your heart sounds like. So there are things definitely in the pipeline. And that way he can also keep the recording, he or she can keep the recording and, listen to the changes over time of what your heart rate sounds like.
Veronika,
Things like
I'm
that.
sensitive to the time. We do have
Yes,
a live
absolutely.
studio audience that will have some questions.
Sure. And
And
that's the last slide. So that's
that was the
perfect.
last slide. So would it be okay with you if we open it up to some
Oh,
questions?
absolutely.
So we've got our live streamers can type in questions, and I've seen some comments that have come across the screen. And we'll turn first to our live studio audience, and we've got a microphone. Questions for Dr. Panagiotou.
Veronika, please.
Veronika.
Yeah. Oh, Veronika, do you have an opinion or an official stance on Joe Biden's new initiative to cure cancer? What do you make of that? And then also your organization, do they have an official position on Medicare for all?
So we don't have a position on Medicare for all. We have supported the Affordable Care Act extensively in the past, and we realize that that the Affordable Care Act, there needs to be improvements to make it more accessible for all. But no, we don't have a policy position on Medicare for all. We are excited for the on our website we have posted about the Moonshot initiative, which I think is what you're talking about. We are excited for any initiative from the federal government to recognize that cancer, that the without a cure, we are the survival rates of cancer are still not adequate. We don't have a position on whether we need a cure, but we need better access, and we need better long-term survivorship care, and we need coordination amongst hospital systems and within hospital systems. And there's a lot of different pieces that you could pull out that need to be improved even before the cure. So you can visit our website to see our official stance. And I will say that I am the Advocacy and Program Manager. And so our Director of Policy, who knows more of the details than I, if you would like to reach out to me, I will be more than happy to forward any questions that you may have specifically about policy that I may not be able to answer. But no, we advocate for any step closer to get to that cure. But there are a lot of steps before even a cure that our healthcare system needs support.
It's certainly having the President of the United States reignite the Moonshot, which was launched when he was a vice president, and his personal connection to cancer, to have more of an emphasis to set some firm goals and to work toward it is definitely advantageous.
Absolutely.
Other questions? We have another question. Getting the microphone.
Yes. Personally, what I experienced, and I was wondering what your thoughts were when, as a patient, when you're going for tests and the first thing they ask you about your insurance and all that, and you try to get out of the way, and they say, oh, well, how would you like to pay that? And I'm like, what? And I said, why do you not put it through the insurance first? Are you sure you don't want to put a down payment? It put a lot of pressure on me, because I'm thinking, are you saying I can't do this test unless I pay? So has that been brought up in any of your surveys about that?
Oh, I mean, no, I don't think we specifically asked about, but the being able to, the first hurdle is, are you in network? Are you out of network? Can you even get this test? A lot of people talked about pre-authorization as a huge issue, but not specifically, to my knowledge, about that's a policy in your healthcare system. That's not necessarily a policy or a law that says that that's how they operate. And so, I would encourage you, things like that are policies and procedures in your hospital. I'm sure that they have a patient committee of some sort or a feedback mechanism. Please let them know about how you felt about that, being in that position. Advocate for yourself so that you're not, again, put in a position like that, and so that other people who don't have the ability to advocate for themselves, that's what NCCS really worries about. We worry about the people that don't have the capacity to advocate for themselves or don't have the wish to advocate for themselves. And so what can we do to streamline, to bolster advocates in communities to be able to help those who, are just suffering through it? And so I would encourage, that's not something, I mean, to me, that is, in my experience, that's so possible, right? Like 100% believe that that's exactly what happened to you. But
I will say, Veronika, I mean, and I totally agree. And I think that you could have a policy and the way it's implemented and just the human communication. But, one advance of we just passed a law on surprise billing. But part of implementing surprise billing, when you get to the guts of the law, is the health systems need to, within a day, give estimate of what is the cost of the service you're going to be getting. And then part of that is, what is the reimbursement and how is it going to, so
it's very complicated.
It's very complicated to do.
And it's also they should be, there's a law that the healthcare system should publish their costs.
Yes.
There's one thing to pass these laws. It's another on how they're implemented.
Exactly.
And who's the authority to say that it was done right or wrong? So I encourage you to, in your advocating in your local space is sometimes even more important than at the federal level, what we do, because you can make more change and a better quality of care in your community if you do speak up and say, this is not right. And so we definitely encourage and empower advocates to make and to speak up.
We have time for one more question. Are there any that have come through online, George? No?
Well, I would say the one thing that struck me tonight was the education component of survivorship, because I was diagnosed more than 10 years ago and then just diagnosed fairly recently with cardiomyopathy because of the chemo. And the only way I uncovered that was through my sports watch, because it told me 4 different times that I had an abnormal heart rate. Went into the cardiologist and he said, "Why are you here? You have no other symptoms." And I said, "Well, my sports watch told me so." And he laughed, but I did the test and found out that's exactly why I should have been there. So however we can advocate and educate survivors about what may or may not be around the bend is really important.
Excellent. Thank you, Chris, for sharing that. And thank you, Veronika, for sharing your personal story as well as sharing your expertise. So this is going to be a wrap. Last word, Veronika?
It's been a pleasure. I'm glad. Thank you for having me on. And if anyone would like to reach out, feel free to reach out at www.canceradvocacy.com, and our contact form will be sent right to me. So I hope that you'll join us in Washington if you'd like. And thank you.
Great. Thank you, Veronika, and thanks everyone for attending. If you know someone that might find this video podcast useful, it is available on demand at the Above and Beyond Cancer YouTube channel or at the Mercy Cancer Center website. Thanks again for joining us, and we'll see you again next week. Bye, everybody.